Welcome to the GI Hepatology Academy, presented by the Department of Continuing Education, Harvard Medical School. My name is Dr. Sanjeev Chopra, and you are tuned into the live session called Rethinking Clostridium Difficile, Old Bug, New Challenges with Dr. Thomas Lamont. Dr. Lamont was formerly the GI Division Chief at Beth Israel Deaconess Medical Center and is Professor of Medicine at Harvard Medical School. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. I'm now delighted to welcome Dr. Thomas Lamont to give his talk.
Thank you. This morning we're going to be talking about an old bug and its current challenges in our hospitals and clinics. This slide shows Clostridium difficile by electron microscopy, and the salient feature I'd like to draw to your attention is that red organelle, which is in the lower left-hand side. That's the spore of Clostridium difficile, and it's that spore which transmits the disease. So Clostridium difficile means the difficult Clostridium. The organism was discovered in 1935 by Hall and O'Toole, microbiologists at Pennsylvania University, who were studying how the baby acquires the bowel flora. When the baby comes out of the birth canal, the GI tract is sterile. But within weeks and months, the baby acquires the flora from its environment and primarily from the mother. What Hall and O'Toole found was a gram-positive toxin-producing bacillus that was harmless to these infants. So what they discovered, as we now realize, was the infantile carrier state. Clostridium difficile was living within the bowels of these healthy babies and not causing any problems. It wasn't until 1977 that investigators in London and Boston identified C. diff as the cause of antibiotic-associated colitis. And now we know that this organism is found on every continent and is a huge cause of disease worldwide. This is the simplified schema of pathogenesis. Nearly every patient who gets infected with C. diff has taken an antibiotic. This antibiotic reduces the protective colonic flora. So all of us have within our bowel a group of microorganisms, probably bacteria and probably anaerobic bacteria, that keep out pathogens. Without antibiotic therapy, C. diff cannot get started in the bowel, and it simply passes through. However, if the protective colonic flora has been inhibited or reduced by an antibiotic, C. difficile is actually able to vegetate, to grow, and release toxins into the lumen. These toxins cause diarrhea and colitis. So in a way, the pathogenesis of C. diff is something like cholera. But the difference is, in C. diff, the diarrhea is extremely inflammatory and not the pure watery diarrhea of cholera. So this is what pseudomembranes look like. Pseudomembranous colitis was actually described in 1895 by a surgeon who had performed a gastrectomy on a woman who eventually died, and at autopsy her colon looked like this. This was decades before the discovery of antibiotics, so that indicates that there may be other causes of pseudomembranous colitis besides C. diff. Here you see the yellow membrane, and it's called a pseudomembrane or false membrane because it's sitting on top of the real membrane, which is the pink or salmon-colored epithelium that you can see, especially in the upper right picture. We also know that in the last 10 years or so, there have been discovered a number of variant strains. One in particular is called Super C. diff. It has a mutation in a gene that allows for increased toxin production. This super strain is also referred to as NAP1 or BI, and it's resistant to multiple antibiotics, especially fluoroquinolones. One of the things that makes this Super C. diff so problematic is the fact that it has increased fecal shedding of spores. So the watery stools of patients with this are loaded with spores, which are the infective agent. There's increased severity, death, and recurrence, and is very frequently associated with epidemics within a hospital, within a city, or within even a larger geographic area such as a province or a state. So I'm going to turn now to the role of the immune system in C. diff pathogenesis. Understanding this part is important for understanding recovery from disease and also the carrier state, and finally the situation with recurrence. So we know that infection with C. diff produces responses from the immune system, the formation of IgG and IgA antibodies. These antibodies are directed at the toxins. They bind to the toxins, there's two toxins, A and B, and neutralize them. We know from animal studies and some human studies that a high IgG level of antitoxin is protective. And furthermore, we've done a lot of studies to show that vaccination with toxins in animals is very protective. What about in humans? So this slide shows the widespread frequency of antitoxins to serum A and B in Americans by age. So on the horizontal axis is age going out to age 80. And the vertical axis shows the percent of patients, these are blood donors actually, and also patients who are not ill with C. diff, the percent of those that are positive for antibody. And what you can see after age 1 or 2 is that 60 or 70% of the American population have antibodies against C. diff toxins. How can that be? Most of these patients never had the disease C. diff, but yet their serum is positive for these antibodies. This reflects the infantile carrier state. As I said before, babies from the time of birth on, up until about age 1, carry C. diff in their stool, and during that time they develop antibodies. The question is, are these serum antitoxins or antibodies protective? In other words, at age 70, if a person comes to the hospital for surgery and gets an antibiotic and C. diff enters their system, are they susceptible to it, or are they immune and thereby protected? So let's just review a little bit about the C. diff carrier state. I've mentioned that infants less than 1 year carry C. diff. How can they be resistant to an organism which produces lethal toxins? We think the answer lies in the fact that they lack toxin receptors. So toxins and their receptors are like a lock and key mechanism. And without the receptor, which is like the lock, the key, the toxin, cannot turn on the flood of diarrhea. We know that hospitalized adults, some of whom have had C. diff, also can be a carrier. And finally, the carrier state is quite rare in healthy individuals who are not taking an antibiotic. So again, I'm going to define a carrier then as a person who is carrying pathogenic C. diff in their stools. This can be detected by assay, but do not have any symptoms. This is sometimes referred to as the asymptomatic carrier state. So let's start with this question. A 76-year-old man with resolving C. diff is on his last day of oral metronidazole therapy for C. diff diarrhea. He has not had diarrhea for the last 5 days and states that he's back to normal. On the weekend, his doctor ordered a stool assay for C. diff toxins, which returns positive. Which of these actions would you take now? Would you continue the Metro for 10 more days and test again? Would you switch to Vanco for 10 days? Or would you switch to fidaxomicin for 10 days? Or 4, would you finish the metronidazole and advise the patient to call you if he develops diarrhea? So think about what your response would be here, and then we'll talk about the answer and why 4 is correct. So this patient is a post-convalescent carrier. He's responded to the metronidazole. His infection, his diarrhea has stopped, but his stool is still positive for the organism. And that is explained on this slide, which shows in the black bars, so focus just on the black bars, something called the post-convalescent C. diff carriage state following successful therapy. So on the far left, prior to treatment, just the black bar, 100% of patients are positive for C. diff. Then treatment commences, and you'll notice the black bar going down. If you look at the middle of the slide, at the end of treatment, only about 5% of patients are still positive. By the way, these are patients who recovered now. These are not patients with recurrence. Once you stop the treating antibiotic, in this case metronidazole, notice the bounce back. 1 to 2 weeks after treatment, about 40 or 50% of patients have positive stools. Some patients, even 5 to 6 weeks after successful treatment, are still positive. And this can go on actually for even longer than is shown on this particular slide. So that leads to the following test guidelines. The best kind of test is PCR, not ELISA. ELISA was a second-generation test, and PCR is the current third-generation test, which is highly recommended. It's rapid, it's sensitive, and it's specific. The second bullet point, I think, is the most important one on this slide, and that's test only unformed stools. If a patient has formed or normal stool, we don't care about C. diff being there, unless we're an epidemiologist. The patient is probably better. Finally, do not perform a test of cure because of the slide that I just showed you, indicating that healthy, recovered patients will be carriers, asymptomatic carriers, for periods of weeks or even months. Correlate the test results with a clinical picture. And again, just to stress it again, 60 to 70% of healthy babies will be positive sometime during the first year of their life. So let's look at adults now that come to the hospital, take an antibiotic, and become infected with C. diff. This is a study that was performed at Beth Israel Deaconess Hospital by my colleague, Dr. Kieran Kelly, and it shows what happened to a group of patients who were followed very carefully with stool cultures for C. diff in the hospital. So start at the left top. 540 patients were evaluated, and 311 were eligible for the study. They had to be in the hospital, they had to stay longer than 2 days, and they had to be receiving an antibiotic. So there were 271 patients enrolled over just a 3-month period. Notice the colonization rate. That's the first, after the first horizontal arrow. A colonization rate, that means C. diff was in the stool in about 1/3 of the patients in the hospital. Of those 84 patients, 47, going upward, were cases, that is, they had diarrhea. 37 patients, almost equal in number, were just carriers. They had no symptoms, but it was in their stool. And notice then on the far right of the slide, some patients came in with the pathogen, that is, they had C. diff on the very first day of admission or pre-admission. and others acquired it in the hospital. The purpose of this study is given in the title of the slide at the top. Do serum antitoxins protect against C. diff in hospital patients receiving antibiotics? And again, this goes back to the idea that during the infantile carrier state, 60 or 70% of patients acquire antibodies to the toxins of C. diff. And here's the result of the study. And what it shows is that we're looking at IgG antitoxin to toxin A. That's on the vertical axis. And on the bottom, we're looking at patients from the time of admission to the time of discharge. The top line, labeled carriers, shows what happens to carriers. They come in with a somewhat higher elevation of toxin, or level of antitoxin, excuse me. And then they have a memory antibody response. That's why it's going up. That's also referred to as an anamnestic response. So carriers have been exposed to C. diff in infancy, probably. And once they see the toxin again, it's as if they had mumps and mumps virus came into their oropharynx. They would have a memory response and their antibody would go up. Notice cases then, those are the arrows, the circles at the bottom. Patients who develop C. diff disease do not have that memory response. So we conclude from this that serum IgG antitoxin A protects against C. diff in hospitalized patients. So that allows us then to revise our pathogenesis schema as follows. Antibiotic therapy, again, reduces the colonic barrier flora. These, by the way, are mostly Bacteroides species, anaerobes that live in the colon. Then the patient ingests C. diff. It's in the environment. It gets into the mouth. The spores come into the mouth. It vegetates in the colon, releases toxins. Now, if that person on the left side now, at the bottom, has been exposed earlier in life to C. diff, they will have an effective memory response and they will be carriers. If, in fact, they've never been exposed before or have no antibody, they will develop diarrhea and colitis. This doesn't explain why only a small percent, say 1 or 2% of patients, get C. diff in the hospital. Those are related to other factors that aren't explained by this. Here is one factor that seems to increase the propensity to develop C. diff, and that is the acid barrier in the stomach. So on this slide is shown the risk ratios for acquisition of C. diff diarrhea according to whether or not the patient was taking an acid suppressive drug prior to exposure. And you can see there, if patients are taking no acid suppression, they have a low risk, and that this increases in a sort of dose-dependent fashion. H2 blockers increase it at least double over background. 1 PPI daily increases it more, and then more than 1 PPI, or proton pump inhibitor, really increases the risk of infection. You would think that this would tell us that acid in the stomach protects against C. diff. The problem is that we know that spores of C. diff are acid resistant. They're also ethanol resistant. So it must be mediated on some other facet of the organism, possibly the vegetative form, not the spore form. At any rate, this relationship between proton pump inhibitors, acid suppression, holds up in other enteric infections, and I've listed a few of them here. On the top, Salmonella. There were 2 studies of this, and both showed that patients on PPIs are more sensitive to develop Salmonella if exposed, and the risk ratios are on the side. Those are quite high risk ratios. Same for Campylobacter. There were 4 studies of this, and in all 4, proton pump inhibitors greatly increased the rate of infection. Then I've just included at the bottom half of the slide 27 studies of acute C. diff, and about 17 showed increased susceptibility. And finally, on the bottom part of the slide, recurrent C. diff, 3 studies on this, and all 3 show that proton pump inhibitors definitely increase the risk of recurrent disease. So what do we do with this information? Does it have a practical impact? As you know, stopping proton pump inhibitors in patients that have had GERD and other symptoms of acid reflux is not easy to do. There's often rebound hyperacidity, and patients can become very quickly symptomatic. Yet we know that there seems to be a relationship here, especially in recurrent disease, that might warrant an attempt at stopping or reducing proton pump inhibitors in patients that are in this situation. This is a question I've heard many, many times, and I suspect many in the audience have heard as well. A 65-year-old woman had C. diff after she took Cipro, and then she was treated with oral Vanco with cessation of diarrhea quickly after 5 days. She took Vanco for 14 days, and now she comes to the office 2 months later for a follow-up visit. She's had no further diarrhea and feels very well. So she's recovered. She has 2 questions. Can I safely take antibiotics in the future, or will I get C. diff again? This can sometimes be a very big question to people that have had severe disease because they were very sick and they definitely don't want to get it again. A second question often is, what antibiotic or which antibiotics are best for me? So this is often a call I get from patients who are actually in the dentist's office, and the dentist wants to prescribe something for a dental abscess or even as prophylaxis. And they want to know right then and there, which antibiotic do I recommend at that point? So my opinion on this is based on the following facts. A second bout of C. diff years later is very rare. I'm not talking about recurrence here. We're going to get into recurrence in a few minutes. This is at least a year after the first attack. And as you'll see in a minute, this is related to antibodies, which can be protective. And you can get antibodies in 2 ways. Firstly, as an infant, which I've already spoken about. And finally, after your bout of C. diff, if you're unlucky enough to get it. And the choice of future antibiotics should be based on diagnosis and culture results. That's what our infectious disease colleagues would tell us. And there is some evidence that probiotic prophylaxis during antibiotic therapy may help. It certainly helps against diarrhea, and it may help prevent C. diff. Let's turn now to recurrence. This is really the major problem with, I would say one of the major problems with C. diff, is this recurrence rate that can be up to 30% after successful therapy. So we define it as reappearance of diarrhea in a person who was recovering or recovered, and this can occur anywhere from 2 days to 6 weeks or even 90 days is what we use in studies after stopping the metronidazole, vancomycin, or fidaxomicin. This results from reinfection of the patient from spores that are either still within the patient or from the environment of the patients. And this occurs before the barrier flora have reconstituted themselves. As I'll show in a minute, this takes some time. Multiple recurrences are common. We have patients in our practice that have had 10 occurrences or even recurrences or even more. And the usual initial response is to repeat a course of either metronidazole, vancomycin, or more recently fidaxomicin. These are some studies that just show the cure rate on the left and the recurrence rate on the right with a number of antibiotics. So let's start on the left half. Cure rates with fidaxomicin and vancomycin. This is total cure rate without any recurrence, is in the high 80% range. Notice that metronidazole, the 4th bar over, is much lower. So metronidazole is not as good as vancomycin. It has the advantage of being inexpensive. Shift your gaze now to the right side of the slide, recurrence rate. We'll start on the far right. Metronidazole has a recurrence rate in a number of studies of around 27%. Vancomycin, around 25, 23%. And notice then the smaller bar, 15% for fidaxomicin. So the great advantage of fidaxomicin is that it has a lower recurrence rate. But I show the slide to emphasize the recurrence rate of about 25 or 30% in both vancomycin and metronidazole. So let's look at this. Why do some people get recurrence? So following up on the same study I showed you before, there were 63 patients in that study that had initial C. diff. Notice the death rate there, 30% died, not from C. diff. The cause of death was not listed as C. diff, but as you probably know, it's certain that the C. diff certainly didn't help things. And then notice the relapse rate there. 35% had an initial relapse, and then another 10 patients had a second relapse, and actually from this group of patients, a number had third, fourth, and fifth relapses. So some patients get better and stay better. That's called a single episode. So what does the immune system have to do with this? So this is similar to the slide I showed before. Here we have serum antitoxin, and there are arbitrary units on the vertical axis, and then on the horizontal axis, the days after colonization by C. diff. That is the day they became positive for the disease. I'd like to draw your attention to the red line, which shows something happening on day 9 in patients that had a single episode of C. diff. That is, they got C. diff in the hospital, they were treated and cured. And what you notice there is a bounce up in that antibody titer. Those patients are developing a primary antibody response. There's the asymptomatic carrier line, which you've seen before at the top. Those are people that were probably immunized during infancy by being carriers. And then finally at the bottom in yellow, recurrent patients who do not develop an antibody. So we think the immune system also explains recurrence. So this is an important point to remember. The best cure of C. diff is to allow restoration of the normal colonic flora after antibiotics. The problem is it may take up to 12 weeks. So virtually any kind of antibiotic can affect the flora of the bowel, and getting it back to where it was can take some time. When that happens, C. diff can no longer colonize, and that's the end of the story. Here's some strategies for recurrent C. diff, and I'm going to give you details on all of these in the next slides. So the main thing we recommend is a 14-day repeat course of either Vanco or more recently fidaxomicin. We'll try to put those two drugs in perspective in a few slides down. We also use a pulse-tapered 6-week course of Vanco that I have on one of the slides upcoming. Remember that probiotics are adjunctive. They're not primary therapy. We don't think that you can cure yourself with a probiotic if you have recurrent C. diff. We have to think about how fidaxomicin fits in here. As you know, it's pretty expensive. When should we use it? We can boost immunotherapy. I'll show you one way that's been invented to do that. And finally, we'll talk about something new called stool transfer. It's relatively new. And very new is something called repopulate, which is actually artificial stool. I'll show you a little bit about that in a minute. And then finally, we'll end with vaccination. So this is what we do in our hospital for patients that have had a second recurrence. That is, they've had an initial disease, they've had recovery, and then they had a recurrence. And now, after that recurrence, which was treated, they've got another recurrence. So this is bout 3. We do this tapered course here, which is called a pulse-tapered dose. And we follow that with 4 weeks of cholestyramine or a probiotic just to help the flora recover itself. Notice that we're giving the drug intermittently and sort of withdrawing it, hoping that the patient's flora over this period of 6 weeks or so will eventually recover and allow exclusion of C. diff. Here's the one paper that seems to show a very strong protective effect of a lactobacillus probiotic in patients with C. diff. It was published a few years back. It's from a hospital, and what they did was at the time of admission when patients were going to receive antibiotics, they were given 1 of 2 doses of a lactobacillus containing probiotic. And those are the right 2 columns where it says 50 times 10 to the 9 colony forming units, or 100 times 10 to the 9. So these are 2 different doses, low and high, of a probiotic versus a placebo. Look at the data under placebo. the incidence of antibiotic diarrhea was 44%. In addition, a whopping 25% of the patients got C. diff. Notice with the low dose and also the high dose that there was marked diminution of both diarrhea and C. diff diarrhea. If this were true and confirmed in more than one study, notice this is less than 100 patients per group, we would probably be putting this probiotic on the tray of every patient when they enter the hospital. This is an outstanding result and could be a way to prevent C. diff in the future. Let's do another case. This is an 83-year-old doctor who has severe CHF and is awaiting aortic valve replacement for critical AS. He had C. diff in the hospital about 18 months ago, which was so severe because of his heart disease that he required hospitalization. He subsequently had 3 severe recurrences, all requiring hospital stay. His cardiac team have advised him that he cannot have his valve replaced until his C. diff is cured. He's currently on a pulse-tapered vanco regimen with probiotic coverage. He's tried intravenous immunoglobulin, he's tried rifaximin. He absolutely refuses a stool transplant. So what should we do with this unfortunate gentleman? So what I did for him was to put him on low-dose vancomycin indefinitely. This is 1 tablet, 125 milligrams daily or every other day. And it's suitable for elderly patients with comorbidity or limited lifespan. I have a number of patients in nursing homes who are taking 1 tablet of vanco every other day to control recurrent disease. These are patients who cannot tolerate a fecal transfer, which would be a better choice, and have recurrences which are life-threatening or nearly life-threatening. The disadvantages are vancomycin is expensive. It predisposes to vancomycin-resistant enterococci, and it's really not based on any trial data. However, it's a useful approach in a tough situation. We should also mention here fulminant or severe C. diff. These are patients who come in the hospital with severe symptoms, and they often come in with mild disease and worsen quickly if for any reason the diagnosis or treatment is delayed, or if antidiarrheals are given. So Lomotil, Imodium, and opiates can make C. diff very much worse in a very short period of time. So we think that prompt diagnosis and aggressive therapy are really critical here. Again, we don't have evidence-based information about therapy. But these are the markers of severe infection. One of the easiest to collect is actually a high white count. We've seen patients with white counts of even 30, 40, or 50,000, almost like a leukemoid reaction, with fever and dehydration. Some of them develop thickening of the colon by CT scan, megacolon or ascites. And then the other complications are listed here. We're especially worried about patients who have tachycardia, hypotension, abdominal distension, azotemia, and confusion. These are usually bad signs in patients that are infected with C. diff. I'll briefly show here that vancomycin is more effective than metronidazole for severe C. diff associated disease. So patients were called severe if they had age greater than 60, temperature of 101, low albumin, or high white count. And you can see by just looking at the red bars and the yellow bars that if patients didn't fit this criteria and had only mild or moderate disease, that in this study at least, vancomycin and metronidazole are more or less equivalent. But in patients with severe disease, vancomycin was very much superior. Here's our recommendation for fulminant colitis. These are found in the reference given here, so-called Shea guideline. So we give large doses of vancomycin orally, and we give either vancomycin or fidaxomicin at the dose shown there. We deliver metronidazole by vein. This drug can reach the colon through the bloodstream. In some patients, we give a vancomycin enema. This is given as a retention enema in saline. Some patients to survive are going to require subtotal colectomy for perforation or megacolon. with an overall mortality of 35%. We used to recommend intravenous gamma globulin, but that has been shown to be ineffective, so we don't recommend it anymore. Here's a 42-year-old man with acute C. diff infection that recurred twice and finally responded to treatment with a pulse-tapered regimen of Vanco. After cessation of therapy, he had recurrence of diarrhea and right lower quadrant cramps with distension and gas. A C. diff assay was negative twice. His symptoms worsened and he was started on Vanco 125 4 times a day with improvement. Again, when the vancomycin was stopped, he got mild diarrhea 3 or 4 times a day, frequent passage of clear mucus, and tenesmus. His physician ordered a colonoscopy and biopsies which were normal, and he did not have celiac disease. What do you recommend now? Test him again for C. diff, perform an upper endoscopy and biopsy, do an x-ray of his bowel, or treat him for IBS. The correct answer is number 4. This patient has post-infectious IBS, which occurs in about 10 or 15% of patients who successfully been treated for C. diff. Patients can also get collagenous or microscopic colitis. That's why the biopsy is performed. Think of celiac disease triggered by an infection. This occurs in some patients. And finally, we know that patients with inflammatory bowel disease can have C. diff infection as well. This slide has an important point. A patient might say, the Vanco doesn't work anymore. In this case, a 71-year-old female with a lot of C. diff in the past, but now on Vanco 125 milligrams 4 times a day. She's an outpatient. She's complaining of 3 or 4 pasty, soft stools per day and feels poorly. Her stool test was positive for C. diff. So patients who get diarrhea while taking Vanco do not have bacterial resistance. It doesn't exist. If you take the C. diff from their stool and culture it in the laboratory, it's exquisitely sensitive to Vanco. We do see clinical resistance, that is in patients with severe or fulminant disease. So if patients are being treated with vancomycin or other drugs for C. diff and they're not getting better, you might think to ask, is there some other cause of diarrhea or are they not taking the medication? Finally, I'll describe something that's come up over the last 5 years, which we think is, has an important message and an important future, and that is stool transfer, taking stool from a healthy person and putting it into the colon of a patient with recurrent C. diff. So the rationale is that the normal flora, which have been inhibited by antibiotics, are no longer present, and what we want to do is to seed the lawn with new healthy bacteria. So we find a stool donor, usually a healthy relative or a family member, and we make sure that they don't have any diseases that might be transmissible, such as hepatitis, AIDS, etc. And we make a stool suspension, and this can be put in either by a nasojejunal tube, by enema, or by colonoscopy. This is very successful, and a cure rate of about 90% or even higher has been recorded right up to the present time. And here's proof of concept in the only randomized controlled trial ever done on this that was published just this past January in New England Journal of Medicine. This is from Holland, and the investigators made a suspension of stool and put it down an NG tube. The success rate on the left bar is about 80%, 90% in patients who got the infusion. Vancomycin was given to another group of patients, and then some patients also had bowel preparation plus Vanco. And you can see the differences there. This proves that the idea is valid and it's not just a placebo effect. The latest development here is something called artificial stool. In this version of Scientific American, just published recently in a journal called Microbiome. This was actually the first article of the first volume of this journal, Fake Fecal Transplants for Gut Repopulation. I was giving a talk in Norway recently, and someone in the audience had heard of this and asked me if we were using it in Boston. I had to say I hadn't even heard of it, but you probably are going to hear about this. So instead of getting stool from a donor, these individuals treated 2 patients with artificial stool. They simply took cultures of gut bacteria, freeze-dried them, and gave them as basically a probiotic. So the future is, I think, interesting and important. We'll probably be using artificial stool. We'll be delivering it by the mouth or by the rectum, not doing a colonoscopy. We'll probably use a few species of bacteria. We're already starting a therapeutic trial in Crohn's disease using fecal transfer, and some are recommending that it be given for patients with acute C. diff in the hospital. Here's the results with vancomycin. I've already with fidaxomicin, and I've circled in the middle there the important part. The relapse rate is half as much as with vancomycin. Otherwise, they're identical. And it probably results from the fact that fidaxomicin is less damaging to the flora. It doesn't knock out things like Bacteroides, which are really part of the protective mechanism, as shown in this slide. And for first recurrence, it's better as well. So fidaxomicin or Difficile in the dark line versus vancomycin in the broken line. Again, it's better. The problem is it's a lot more expensive. So scan this slide, go down to the 4th category there. Cost in the hospital, a 10-day course, $3,000 for vancomycin. I'm sorry, for fidaxomicin versus $70 for vancomycin. I'm sorry that they've been reversed at the top there. So vancomycin can be prepared fairly cheaply from IV preparation, which can be just diluted with water and given orally. Both of the drugs have minimal side effect. So at this point, fidaxomicin is a better drug, but it's just a lot more expensive. This will probably appear in the market in a year or so. It's an antibody that's prepared as a monoclonal antibody, and it's given to patients at the beginning of their treatment, a single injection of an antibody. And you can see on the bottom that the recurrence rate was markedly depressed. This is my final slide, and what it shows is what I think is the future. On the left, the information I've already reviewed about how carriers have a higher antibody rate and you need an antibody to get better. And on the right side of the slide, the results of vaccinating healthy young men with a toxoid of C. diff and showing remarkable antigenicity. And what we're doing now and what others are doing with drug companies is trying to show this as an effective prevention of C. diff in practice. Thank you for your attention.
Thank you very much, Dr. Lamont. Several questions. The first one is by Dr. Linda Hunt. How long after taking an antibiotic may C. diff develop?
Yes, it can be very quick. It can be during the antibiotic treatment, or it can pop up to 60 days later. So we do have delayed onset. And sometimes patients are having small amounts of diarrhea that they don't report, and then finally develop watery diarrhea with other symptoms up to 2 months after the initial exposure.
Terrific. A question from Dr. Pupula. Does vaccine and IgG antitoxin A give a lifelong immunity to C. diff?
Well, we don't know yet. As you're aware, some vaccines require booster shots. For example, DPT usually requires a booster. So we don't know. What we're impressed with is that patients who develop antibody during the carrier state in infancy seem to be protected for life. So I'm going to say it'll probably last a long time once we perfect it.
Okay. You mentioned probiotics. There's several questions. Any particular probiotic that you would recommend?
We use VSL, which is a mixture of various bacteria. And we sometimes use Florastor, which is a probiotic yeast called Saccharomyces boulardii. This was developed in Europe. It's available in the United States over the counter. It is expensive, and it seems to have an effect in preventing or helping prevent antibiotic diarrhea. It's not clear if it cures C. diff, but in animal studies it seems to compete with C. diff for a niche in the colon.
Here's a question from Dr. Kimberly Beavers. I thought that because fecal microbiota transplantation, or FMT, is not approved for any therapeutic purposes, an investigational new drug or IND application is needed for the use of FMT to treat any diseases, including C. difficile.
That's correct. The FDA has ruled at a recent meeting, actually just last week, that an IND is required because this is a treatment, an experimental treatment given to patients. Up till now, practitioners have simply used this without getting an IND. When asked at this meeting, would the FDA or anybody else prosecute, or do they have any way of finding out if you're using this without an IND, they chose not to answer. So I think it's best for practitioners using this to get an IND, which we have, and it's certainly required for any IRB-approved treatment of, for example, something like Crohn's disease, other forms of IBD, or even IBS, where it's been tried.
Okay, let's take a final question or two. Dr. Gramutuik, what is the role, if any, of C. diff in colon cancer?
I don't think it has any causative role in colon cancer. We used to think it might be involved in something called sudden infant death syndrome. This is a long way from colon cancer. We're going back to infancy now. Because 70% of babies carry large amounts of this toxin in their stool, and because we know that if we inject the toxin into experimental animals, that they die a quiet death, something like crib death, we had the idea that it might be related to crib death or SIDS, but we don't think it is. So I don't think it has any relationship to colon cancer.
Question here, can you comment on binary toxin?
Yes, binary toxin is produced by the so-called superstrain or NAP1-BI. Its function is not known, so at the moment it's a laboratory curiosity, and I don't think we need to worry about it. The two toxins, A and B, are a sufficient cause of C. diff colitis, and I think those are the ones we've focused on for vaccine development and other applications.
There's a question from Dr. Aida. What is known about the prevalence of C. diff in Africa, for example, in Egypt?
Yes, I don't have specific information about that, but I've seen a map that shows the spread of C. diff, and it has covered every continent. And we know also that in areas of Africa where babies are born outside of hospital, that even they carry C. diff. So I had the idea initially that perhaps babies or infants acquire C. diff in the hospital where they're born. Most babies in America are born in a hospital, which is loaded with C. diff. That perhaps birth at home or birth even away from any medical care facility would be healthy in this regard. But in fact, babies born in Africa appear to have the infantile carrier state.
It's a very interesting question from Dr. Delcia. Any studies of C. diff incidence after Helicobacter pylori eradication triple therapy? These patients are getting a PPI and an antibiotic.
Yeah, that's an excellent question. It seems to be lower than one would expect. I've treated a lot of patients for Helicobacter pylori, and I have yet to see a case, but I'm sure it can happen for the reasons just mentioned, that you're taking a PPI, which we think is a risk factor, as well as 2 antibiotics. But the incidence is low. The antibiotic that is most likely to cause C. diff is still clindamycin. In fact, the disease used to be called clindamycin colitis, which is unfair because other antibiotics, of course, can cause it. But if you had to prohibit a single antibiotic to patients who ask that question, they should probably not take clindamycin again.
If one does a sigmoidoscopy in patients and you don't see pseudomembranes or colitis, can they be present higher up and only be seen on colonoscopy?
Yes, a full colonoscopy would show pseudomembranes in, say, 30% of all patients infected, whereas a sigmoidoscopy only 10%. So more is better for that diagnostic purpose. However, just to put that in perspective, We seldom do colonoscopy for C. diff. These patients are often very sick, and subjecting them to a preparation and a full colonoscopy is probably more than they need. However, there are occasions when we have a patient who's very ill in the intensive care unit, and we want to know if they have colitis or not, especially in the rectum, that we do a very limited sigmoidoscopy just to see if we can see one pseudomembrane so that we have a diagnosis.
Right. Let's take a final question. Please repeat the names of the probiotics you recommended.
There's one called VSL3, which is available now in health food stores, and Florastor, or Saccharomyces boulardii, is available over the counter in pharmacies in the United States and Europe.
Terrific. There are several comments saying, very good talk, thank you very much. I want to add my thanks to that, Dr. Lamont. Thank you so much.
Thank you.
I would like to thank Shire Viropharma Incorporated, UCB Inc., and Ferring Pharmaceuticals Inc. for their support, unrestricted educational grant support for this important educational activity. Please remember to complete the quiz at the end of the session in order to secure your CME credits, and stay tuned for the next session, Screening for Colorectal Cancer with Dr. Daniel Leffler. My name is Dr. Chopra. Thank you again for joining us.